Good morning, everyone. I'm Shekhar. I'm an imaging fellow at Morning, and I'm Morning side. Uh, Before I start the presentation, if you can scan the QR code or log in through the poll EV link at Shekhar Vora 159 so that you can participate in the poll while I start with the case. Uh, yeah. So for our case, is for 30-year-old female who presents to our ED with a 2.5 hours of chest pain while she was resting. It was mid-sternal, non-radiating, and non-exertional, not associated with any palpitations, diaphoresis, no loss of consciousness, dizziness, or no positional or any breathing variation. She had received flu vaccine like 5 days prior to this episode and had reported some viral symptoms for 2 days. But at the time of presentation, to the ED, she did not had any chest pain or URI symptoms at the time of evaluation. Her review of systems were negative except for the chest pain. Other history, past medical history, she has had multiple episodes of chest pain in the past, and which were presumed to be after viral illnesses. And throughout these episodes, she has been managed as a perimyocarditis with colchicine and NSAIDs with different places. Uh, she had for the family history, she had one elder sister who was diagnosed as having heart failure when she was a child, and multiple men in the family has had history of CAD and MIs while they were in their 40s and 50s. So for social, she's from Argentina. She was a student at Columbia Business School studying masters in business administration. Social drinker, just 1 to 2 cigarettes a year and no recreational drug use. No known allergies were reported, and only OCPs was the home medicine that she was taking at the time of presentation. At the time of evaluation in the ED for a physical examination, her vital signs were stable, and her all the other examination was stable, as well as the cardiovascular examination, which was normal as well. This was her admission EKG. Uh, Dr. Miller.
Yeah, Dr. Miller, you want to walk us through the EKG, please?
So, yeah. It's basically obviously sinus rhythm, quite abnormal. The QRS is heavily fractionated, so almost guaranteed that there's going to be some amount of scar in the heart. If you imagine like depolarization is like a river.
Please speak louder.
Yes, I'm quite capable of it. No, so can you hear me now?
Yes.
So it's normal rhythm. The QRS itself is very abnormal. There's a lot of fractionation within the QRS. So almost guaranteed there's going to be some abnormal substrate such as scar identified. If you imagine that depolarization is normally a smooth process, like a river or a stream, all the water is kind of going forward. If you start throwing boulders into that river, then the water kind of hits the boulder and has to go around, it slows down. The same thing happens with scar tissue in the heart. As the QRS encounters areas of slowed conduction, you start to develop fractionation either in the QRS, or if you develop it after the QRS, which is obviously quite late, that's essentially the equivalent of a positive signal average EKG, or we call like kind of late fractionation. So likely there will be some pre-existing abnormal substrate.
Are you able to tell what might be causing the scar based on this EKG at all?
No, you can develop fractionation from, for example, like interstitial fibrosis, but that's usually less common. It's more like kind of replacement fibrosis that leads to this. Sometimes you can make out like there are certain diseases that have certain patterns where the QRS becomes fractionated, like infralateral versus anterior, for example. But here it actually seems to involve obviously a lot of inferior scar, a little bit of lateral scar, then a touch of precordial. But it doesn't have like the typical features of like ARVD, which is usually you have these, findings in V1, V2, like an epsilon wave. I would not call that an epsilon wave because it's all within the QRS.
Any concerns for ACS or any pericarditis in this EKG that would?
No, not in this one.
Okay, sure. Thank you, Dr. Miller.
Can you unpack that for me a little bit? Yes, that's not a classic epsilon wave, because in the epsilon wave it would be after the QRS complex.
Yeah, so usually epsilon implies something like arrhythmogenic right ventricular dysplasia, which is usually in the, for example, the right ventricle near the outflow tract, which is usually the latest part of the heart that's activated. And so that delay in depolarization comes very late. In fact, it can be like 60, 70, 80 milliseconds after the main QRS has already completed itself. And it's usually classically in V1, V2, because that's where your outflow tract of your right ventricle is reflected by V1, V2. Yeah, there are definitely certain diseases, which I'm sure we'll get into, in which you can develop like anterior precordial T-wave inversions. But these are not nearly as impressive as you used to seeing in like kind of classic diseases. Like they're there, but not to the point where I would have said like this is typical for a specific disease.
So moving forward, she got the admission X-ray as well. It's a PA view and the lateral view, which shows the normal cardiac silhouettes, and the lung shadows are also normal as well, without any gross pathology. So these are the admission labs the patient had. They were all troponins were elevated at the admission of 105, and the repeat troponins were flat. However, they were still elevated. ES was upper limit of normal. CRP was slightly elevated. Her ANA was positive as well, with the 1 to 160 dilution, and the reflex antibodies which were done to further differentiate were all negative. A respiratory viral panel and the COVID-19 was negative as well. So she got the echo. So this is the plaques view.
Can we have Dr. Agarwal walk us through the echo, please?
So you have your parasternal long axis view on the left side, and again parasternal long axis view on the right side as well. Hello? Yeah. Okay. So parasternal long axis views on the left and right with and without color. The color view seems a little bit off axis, but over here don't see real like left ventricular size, looks okay. No major effusion. Pericardium maybe a little bit brighter than usual, but again, it's a relatively young female, so not much to read. Mitral valve, aortic valve so far looks okay.
So we have a four chamber with the four chamber and the color flow across the mitral valve.
So biventricular size function looks okay. Atrial look okay. The lateral wall, the mid-lateral wall, maybe there is echo dropout or maybe some hypokinesis that may be present over there. The valves by themselves, the mitral valve color does not seem very impressive. So overall, the function is okay, the size is okay. Maybe there may be some regionality in the lateral wall that I can see just from this limited view, tough to say. Right ventricle looks normal because that was one of the things that we were talking about before. Size and function looks okay. Tricuspid valve, again, looks okay. No significant DR on color Doppler. The 3-chamber and 2-chamber. The 2-chamber looks a little bit off axis, maybe tough images. Overall function is okay, but again, I'm not really very happy with the lateral wall. It looks a little bit hypokinetic and sluggish in the mid part over there. But other than that, not anything major.
So given the history and the labs and the echo findings that we have, what are your differential diagnoses?
Can you show that QR code one more time? Just make sure everyone in the audience can participate. There it is. We'll see what responses come rolling in. We got the word map up, right? Okay, myocarditis. Genetic. GERD. Myopericarditis, okay. ARVC. All right, so looking like the most popular answer is something inflammatory. We saw the inflammatory markers were elevated, tropus elevated, but mildly and flat. SCAD in a young woman, okay. We see this term genetic. I think this comes up a lot when we're building out our differential, but of course it's really an umbrella term for a lot of different diseases and concepts. So I wanted to ask Dr. Kantorovich, can you break this down a little bit for us in 2025? What's your system for organizing genetic cardiomyopathies in your head? What are the buckets we should be thinking about here in this case?
Well, there was a positive family history, so I think that's already sort of a clue that there could be a genetic component. I mean, it's kind of a spoiler alert because I know the outcome of the case, but I think in a young person who's had recurrent episodes of myocarditis, there's a few genes that come to mind as being associated with that presentation. And I don't want to spoil the outcome, so we'll talk about some of that. But I think that phenotypic presentation raises a genetic question that fits very well with specific genotypes. How do I organize my thoughts in general? I mean, there's a lot of...
Yeah, just for the fellows, who are kind of thinking about what is under that umbrella of genetic cardiomyopathies. How do you think about that?
There's a lot of overlap between the genetic etiologies of the various cardiomyopathies as they're categorized. So you could have a single gene that can cause a dilated cardiomyopathy, or it could cause an arrhythmogenic cardiomyopathy. So you have to kind of approach it from both directions. Both the phenotype needs to be fleshed out as accurately as possible, and then ideally you back up your diagnosis with a genetic finding. But yeah, I think myocarditis could be considered genetic, DCM could be considered genetic, HCM could be considered genetic. You had the term ARVC up there, which is really an outdated term, but arrhythmogenic cardiomyopathy is another important category. And then there's so much like crosstalk with some of the types of cardiomyopathies that have not traditionally been thought of as genetic, like peripartum or alcohol, kind of similar to what we know about with myocarditis now, where a traditional cardiomyopathy gene can also cause those presentations.
Thanks.
Thank you.
So, and what does the panel think? Are we in agreement this is some sort of inflammatory cardiomyopathy? Anything else you would want to add to the differential?
Can I ask a question? Do you know why they sent an ANA in the emergency room?
I think it was a part of the, to put out a disclaimer first, I think it's majorly a long case. So it was the next day that she had an outpatient visit where it was like sent, but to like club everything together to, for the sake of this presentation, I've tried to make this as it together, but it was just sent as an outpatient the next day. Okay. So, and the next question, so given the diagnosis, possible diagnosis, what would you do next?
Everyone wants the MRI. Okay. I think we're learning something through these conferences over the course of the year. It's more and more certainty. Okay, coronary CT. Okay. What does the panel think? Dr. Correa, what do you think is the right next move here?
So again, because the timeline has been compressed, I had other information to work with, and I think I first met the patient a few months after the stated index episode, but my thought process was very similar to what Dr. Kantorovich so beautifully explained, that because she had a compelling family history, and given the nature of her presentation, my thought was that there's some sort of genetic component to her presentation. I did think that maybe some things could be coincidental. Maybe she had some sort of idiopathic myocarditis for some other reason, but it would be wrong to just put aside coronary artery disease or SCAD or something to do with the coronaries. So my first inclination was to go for a cardiac MRI, but I felt like, considering that she had wall motion abnormalities in the lateral wall and something didn't make sense, I did want a coronary evaluation as well, but I was leaning towards, so that was my approach towards it.
So what happened next?
All right. So she was evaluated in the ER by the cardiology team. Given that she has had a previous history of pericarditis and with some possible troponin elevations, so she was diagnosed as likely myopericarditis at this time. Started on the ibuprofen and was planned for a close outpatient follow-up. That's where she got the air in the next day, and she had an outpatient cardiac MRI done as well within like 2-3 days after her ED visit. This is her short axis cine images.
Can you walk us through the MRI, please, Dr. Agarwal?
So short axis cine imaging from top to bottom. The ventricle overall function does not look that bad. Maybe there is a trace pericardial effusion that you can see around it. There is more trabeculation of the lateral wall of the left ventricle than you would anticipate, but again, she is a relatively young female, so this is not uncommon that we end up seeing. Overall function looks relatively okay, or maybe low normal, and the lateral wall does look a little bit hypokinetic, or it's, if nothing else, it's a little bit more tardikinetic as opposed to the other segments. The RV looks okay over here on this view. Does not look dilated per se, but it does look okay.
All right. So we have the long axis cine as well, 4-chamber. We have a 3-chamber and a 2-chamber as well.
Again, the 4, 3, and 2 chamber pretty much consolidate what we had sort of said before. The overall function is not bad. Maybe there is some hypokinesis of the lateral wall. Importantly, as Dr. Larakas said, the right ventricle looks normal in size and function over here. That does not seem to be a concern for now. Again, we see this trabeculated pattern in young patients, especially young female, thin female. This is not uncommon. But again, in echocardiography, we do not appreciate it as much, but on MRI, you see this quite often. So we have to put this in the clinical context about what we are dealing with.
Moving forward, so we have LG in the short axis view.
So the base, mid, and apical slices, there is a large amount of LG that Dr. Miller mentioned before, and it's almost a circumferential or a ring-like pattern that you see pretty much throughout, right? Worse is probably in the lateral and towards the base in the inferior wall, but you pretty much see it all over. And it's in the subepicardial pattern, ring-like. That's what we have. And maybe like over here it's really difficult to say in terms of if there is any particular segment which is affected more than the others, but it seems to be more of a global process. Some segments affected more than the others. Importantly, the right ventricle looks relatively okay over here. There is no major LG of the RV free wall or anything that we are seeing.
So when you see this MRI and trying to put out of your mind everything else you know about the case, do you still think it's necessary to rule out SCAD or coronary disease in a young person like this?
Yeah, this does not look like a coronary pattern. You know, what you would expect to see in that situation, and please correct me if I'm wrong, is something that was subendocardial and would sort of follow a coronary distribution. This did not look like someone who had a coronary event. So my thought, this doesn't look like someone who necessarily has sarcoidosis. It seemed like either some sort of a genetic cardiomyopathy, which manifests as a myocarditis, or some sort of myocarditis whose etiology was identified.
I make a comment because I think this comes up a lot, especially inpatient. I think I agree with him from a risk stratification standpoint. For example, if someone's in the ER, you want to send them home. You obviously want to, if they develop chest pain and polytroponins, you want to make sure you're not sending them home with something that's going to kill them. So I think if you can get the CT scan on the same day, we often do that. You get a CT scan, you don't think there's going to be any SCAD or coronary disease, it's clean, and you send them home and you finish the workup. But I also agree that if for some reason you ended up with this MRI first, that this is good enough to say this is not going to be coronary disease. I think it's just the order in which it's done is more of a practical matter rather than a, you know, if we could pick and choose what we do, because usually we can get the CTA first, because MRI stuff. Yeah.
Yeah, you know, I think if she had de novo presented with this to the emergency room, she would have had some sort of coronary evaluation. You know, at Morningside, she would have probably gotten a CCTA. But I think against the backdrop of so many similar presentations, including at NYU a few months earlier. She was sort of sent home with no imaging, with a plan for urgent imaging next week. But I totally agree with what you said.
I'm not an imager, but you can't always see a SCAD on a CCTA, right? So if you're thinking along those lines, aren't you then headed toward an invasive angiography?
You could have SCAD causing this type of injury.
Unless it was over on a
Like-
CCTA.
Yeah, right. This SCAD would lead to this type of injury. You could have both, obviously, but they don't go together.
Just one quick thing I would like to say, like, in terms of, playing a little bit of a Monday morning quarterback over here, but again, from full disclosure perspective, when we see this sort of an LG pattern, pretty much the only thing that we can say is this is a non-ischemic pattern. And then everything else is a differential diagnosis based on probabilities, what the pattern looks like. Like 5-7 years ago, genetic cardiomyopathy would not have been the first thing we would be seeing. We would have been calling this myocarditis, some atypical variant of sarcoid or something. But as our understanding, as knowledge has improved, the first differential diagnosis that we'll put on our MRI report will be some variant of genetic cardiomyopathy, but cannot rule out other causes. So the thing that we can say is that this LG pattern is a non-ischemic pattern, but other than that, after that, everything else is a clinical presentation, the whole picture put together, and everything is on the table at that point.
And I think you make a good point. Just there's a lot of opportunity now, and you see, for example, like Moss, a lot of heart failure doctors do this is they're reclassifying these patients. So we have patients that we've been following with like BIVs for complete heart block for like 10 years. That on their original implant, because they came in with like RV dysfunction and complete heart block, we labeled them with sarcoid, and then they've carried that diagnosis ever since. You said genetics on it, and it turns out that they're like LMNA positive, like they have, clear genetic cardiomyopathies that we have not even considered because we're just anchored in this old diagnosis. And I think there's one paper not too long ago where they looked at their clinic and they reclassified all their presumed sarcoids, and 15% had a clear genetic predisposition.
It's a small series out of 10, but it was a little bit higher. Actually, I think it was closer to 30% reclassification.
Even better. So I think, sending genetics on a lot of these patients that we've otherwise treated, there's a fair amount of patients out there that probably we gave a wrong diagnosis to because that was the time.
And again, I think the reason I bring this up, maybe we'll talk about it a little bit more later, is putting all your eggs in one basket with sarcoidosis based on even MRI reads or any reads. Non-ischemic pattern is the only thing that we can say, and everything else is on differential diagnosis. So even the older patients who have been labeled by sarcoid, bread and butter myocarditis, if you end up seeing those patients, it may be worthwhile revisiting their history or having an imager look at the images one more time with the new data that we have, what has been published, and we may be able to find more answers rather than just labeling them as idiopathic myocarditis or sarcoidosis.
These are such important points to keep us at the cutting edge of cardiology. Can we move to the parametric imaging?
Sure. So this is the.
Well, we can do long axis first.
Yeah.
Long axis images, 4, 3, and 2 chamber, pretty much showing the same thing, a large amount of LGE. Over here, the only thing that I would like to add is that I'm beginning to see a little bit more RV-LG also over here. It looks like it, the slices are probably pretty thin, but again, there may be some RV is not totally spared, it looks like over here. So there is both left side and right side involvement potentially.
All right. We want for the T1 weighted images, we have the native T1 global noted as 942, and for our scanner, the normal is less than 1100 milliseconds. And for the global.
So T2, we'll start off with T2 first because that's an easier concept. So T2 is a marker of myocardial inflammation as to how much water you're holding on to. So in patients who have acute myocarditis sort of a situation, or let's say they have a big myocardial infarction where there is a lot of edema, you're going to have elevated T2 values. And your T2 values will be, depending upon the scanner, can vary from 50, 55, 60. So generally, as a rule of thumb, if you're more than 16 milliseconds, then you are dealing with a patient who has myocardial edema. So that is the focus of T2 mapping. So let's say you have a patient who has a big myocardial infarction. Let's say it was a Minoka that was not diagnosed or something, and then you do an MRI and you find it. In the region of the infarction, you will see that there will be elevated edema, there will be increased T2 signal over there, and the value will be more than 60 milliseconds. or let's say there is a big myocarditis episode, then you would see the elevated T2 over there. So that is T2 as far as edema is concerned. As far as T1 is concerned, T1 is a marker of more sort of expansion of the extracellular space, which can be because of a variety of different reasons, including edema, fibrosis, interstitial fibrosis. So in conditions like amyloidosis, your ECV will be elevated. In conditions of acute myocarditis, where you have expansion because of fluid, your ECV value can be elevated. On the other hand, in patients who have fat, your ECV, or sorry, your native T1 values will be reduced. So it is a tissue marker from the perspective that it helps us figure out if it is in a normal tissue characteristic or you're dealing with more with edema or fibrosis versus something like fat. So in this patient over here, your native T1 global is 942 milliseconds. On our scanner, it is closer to 1100 milliseconds as the normal. What you have to keep in mind over here is that we saw in the LG images there was a lot of diffuse, or there was a lot of fibrosis that was there, which was replacement fibrosis, as Dr. Miller mentioned before, because fibrosis happens in a few different flavors. One is interstitial fibrosis, like it ends up happening with amyloidosis. You can have replacement fibrosis like HCM or myocardial infarction. Sometimes regions which have increased T1, they can get balanced out by other tissue which can be healthy. So when you look at a global value, sometimes you can have that balancing out, and it may lead to false values where the global value will look okay, but regions will have, or pockets will have elevated values.
So do you do regional? Do you do by segment?
We do look at it. Again, when we obtain these images, they are generally obtained at 3 levels, base, mid, and apex. So if there is required, we are able to do it by regions. The thing to keep in mind is that this sequence is relatively weaker sequence with more artifacts. So we have to keep in mind if the patient is breathing through it or something. Since this is a static image created from a dynamic sequence, it can be full of artifacts. So for example, if you look over here in the anterolateral wall, you see those yellow spots that are there. Maybe that is abnormal, or that may just be motion. It becomes a little bit difficult. So unless we feel really comfortable calling something which adds up to the whole picture, sometimes it becomes difficult for us. But yes, we can quantify it segment by segment if it comes down to it.
What do you make out of this?
So far we have is normal biventricular size function, maybe some focal wall motion abnormalities. There is a large amount of subepicardial LG, both of the left ventricle as well as some of the right ventricle. Your T2 myocardial edema values are within normal limits, around 58 milliseconds. So there does not lead to be a lot of acute myocardial inflammation that's happening. And then your native T1 global value is 942 milliseconds, which means that there is fibrosis, as we see on the LG, but this is not a diffuse, dense interstitial fibrosis kind of a picture. So you're not dealing with a condition like amyloidosis or something.
Can I ask a really quick question?
You had mentioned that the lateral wall had a lot of trabeculation. And we know that younger patients tend to have much more trabeculated hearts. I'm often skeptical when trabeculation is mentioned, but sometimes in so many MRIs we see the amount of trabeculation described and non-compaction cardiomyopathy is invoked. How do you tell true non-compaction cardiomyopathy, something that gets you concerned, versus just excessive apical trabeculations in a young person?
So it's a concept in evolution, I think, and again, this goes back towards the whole point of how genetics has changed how we approach cardiology and cardiac imaging. We have seen, at least in the world of cardiac MRI, very, very heavily trabeculated ventricles, both on the left side and right side for a long period of time. If you look at the ESC 2023 guidelines, I think, which talk about cardiomyopathy, they have kind of walked away a little bit from the concept of left ventricular non-compaction completely. And instead of calling it as a particular condition, they are beginning to call it more of a phenotype, which may be the end product of a variety of different genetic conditions or other conditions. So for me, when I'm trying to see if this prominent trabeculations or non-compacted myocardium is going to be pathological, you are trying to put it together with other findings. So if you have a patient with normal EF, with no LG, nothing else is going on, then you probably noted that there may be something going on as far as there are prominent trabeculations, but that most likely is not of much value at that point. But if you start seeing that with a drop in EF, or you're seeing that with LG or something else, then you definitely have to start paying attention to that. So Trabeculations by itself in isolation may not mean something, but if you see it with something else, then you have to be careful about it.
So is there value in mentioning those ratios now, especially for someone who does not have a reduced dilated ventricle?
I'm not a huge fan of ratios in general because it just depends upon the ratio literature where you measure it short axis, long axis, echo, MRI. There is too much variation that is there, but it may be worthwhile mentioning it in that context that there is prominent trabeculations. You can make a note of it if you think it would be of value, but just pinning your hat on the fact that there is prominent ratio may be a little bit tough.
Dr. Beanstalk has a question.
Yeah, it's a quick question. All right, thank you. I don't know. I find it a little hard to believe that the global T1 value is normal here with all that LGE. What makes me think, like, I don't know where the MRI was done. You know, a lot of times we use automated software now, Circle, things like that, and they'll try to figure out where the myocardium is and stuff like that. And due to the fact that so much of the scar was subepicardial, really circumferential subepicardial scar, I'm trying to think maybe the region of interest cut off that subepicardium and didn't really include it. Because this native T1 value is so low, I think, and as you mentioned, we used Schmali, Mali sequences, static images, tons of artifact. Usually if, you know, they're not breathing properly, it could be prone to artifact, but I have trouble believing that the real diffuse global T1 value is this low in this patient. And just to say something about the non-compaction situation, I think I completely agree. As you mentioned, it's really in evolution right now. Stefan Peterson, who really is one of the pioneers in cardiac MRI and LV non-compaction, has really walked back non-compaction as a real clinical entity. And that was evidenced by a 2023 position paper in JACC or update in JACC or whatever it was, where they really got rid of the term non-compaction and just refer to it as excessive trabeculation now in the majority of patients. Basically, as you mentioned, look at it with, you know, is there a dilated cardiomyopathy and excessive trabeculation? You know, basically treat the dilated cardiomyopathy based on what you think is causing it, not based on the amount of trabeculation. But yeah, thank you.
That's a very fair point in terms of what you're saying with the T1 mapping. So this patient, this was a free breathing scan. There was a lot of artifact and motion that was there in this. And your point is absolutely valid that in patients, and again, this goes back to the point that Dr. Miller was saying before, is that in patients who have thin walls, breathing artifact, figuring out where the epicardium is, where the myocardium is, and where the pericardium is that may be impinging onto the myocardium, it may be difficult. But yes, your point is absolutely valid that in this patient with this much degree of LG, the chances that your the global native T1 is going to be 942 is pretty slim.
I think one other thing to consider is if this is fibrofatty replacement, then the fat from that scar could actually drop the T1 value. So when you mention averaging, you could get a pseudo-normalization of the T1 value. All right, we got a lot more to get to, so let's keep moving.
So we got the CCTA as well in the setting that she has had a few family history of CAD and MIs, and she has had some troponin elevations and ruled out coronary anomalies as well. Just to give a breather to Dr. Agarwal, I'll just read it through. I think so she had a right dominant circulation with the normal left main, and the LAD and left circumflex was normal as well without any obvious plaque. So for her clinical course, so she was started on the call just after the MRI that she had for myopericarditis. So post this, she traveled to her home country for holidays, and where she had a similar episode of chest pain and was hospitalized, and was continued on the colchicine and NSAIDs throughout that hospitalization as well. Post that, she was in the US. She came to US, and Holter was done. This was a Holter report.
I don't know if you have any comments, Dr. Miller. It looks like 3% PVCs. There was no NSVT. The average heart rate, I think, was in the 90s.
Right, yeah, and she had like one PVC here. So for her, the patient said that her baseline heart rate prior to this episode was usually in 60s to 70s, but after the episode, her heart rate baseline has been averaging at like higher 90s to 100s, and with the Holter showing some ectopy, she was started on Toprol. And throughout this time, she was also getting her labs drawn as well, where she was showing like outpatient lab with mildly elevated troponins in hundreds to 300s without any episodes of any chest pain. She was just having a baseline chronically elevated troponins. Heart failure consultation was done in the setting of low possible EF of 44% on the MRI. She was started on the medical therapy. She's continued on her toprol and was started on losartan as an outpatient. So for her, with the episodes of recurrent myopericarditis and having subepicardial LGE in distinctive ring-like pattern and a positive family history as well. So she was referred for cardiogenetics. When she went there, she had undergone again a detailed history and physical examination. So this was pictures of her hand, and this is one of her zoomed in pictures of her hand. So
Remind us how old this patient is.
So she's a 30-year-old female who is working in Colombia, studying in a Masters of Business Administration and not doing any hard labor, any manual labor, or any contact with any or going to any chemicals as well. So just to go. So what do you think about this? I'll just go over the image. I'll put out the image for your reference.
This is good cardiology board prep now. This topic is coming online. What does anybody think the diagnosis is here? Any thoughts? Right hands look related. Connective tissue. Okay, okay. This is a learning opportunity. Rheumatologic, okay. All right, so I think people may be thinking systemic sclerosis, and you can have scar, non-ischemic scar from that. It's a good point. But keep going for us here, Shekhar.
Okay, so after this one, so we thought that she had calloused hands. She had curly hair, even though she's been using cosmetic treatment to get her hair straightened, but it was mentioned that she, at the baseline, her hairs were curly. I don't have an image to show for that. So she had a family history and detailed pedigree analysis was done. Dr. Yeah.
Can you walk us through this? Can you translate this for us, please, Dr. Kantorovich?
Exposed. Okay, so when you look at the pedigree, start by looking for the arrow that's pointing to the proband. So yeah, exactly. So 31-year-old woman, phenotype is listed as recurrent myopericarditis. And then because that's the prominent phenotype that we're focusing on, there's a shading in the bottom right-hand corner. And so anyone else on the pedigree who has that same shading would have the same phenotype. So the first thing you see is her sister, who's 33. This is the sister that was mentioned in the initial intake family history, who was diagnosed with heart failure as a child. We elicited additional history from her. She had some documentation that she brought in that we were able to review. So the sister had confirmed episodes of VT, polymorphic PVCs in VT. She had a mid-range ejection fraction diagnosed at age 20. Her episodes were also suspected to be myopericarditis, and she had had an MRI that showed fibrosis and LG. There was another sister with no known cardiac disease who had never had any cardiac evaluation. Parents were living. Dad had what was described as a mild MI in his 50s. We put it in quotation marks, and I think that's important also as like a teaching point is when you elicit a history from a patient that there's family members with heart attack, MI, however they describe it, take that with some skepticism unless you're looking at a cath report or an autopsy report, because it could also be something like this or like something that Dr. Miller would see. It doesn't necessarily mean, ruptured plaque and obstructive coronary disease. Patients don't really differentiate that. Also on the paternal side, if you go up one generation, there's a father, there's a paternal grandfather who again died suddenly, quote unquote heart attack at age 50. Everything else in the history is really not that impressive, but the only other thing I'll point out is that the proband has no children. As we're thinking about genetics, we're always thinking about, family decision making, and at the time she was not in that phase of life. I don't know if you're going to say anything about the update with the family history.
I think it was there later, but I think it was the major update that you already mentioned.
Well, there was one major update.
That's coming in a second.
All right, so as mentioned that, so this has been discussed very well by Dr. Kontorovich. So she had a genetic testing done as well as an outpatient, and this was the results. If you wanna.
Can you walk us through these findings and what these mean?
Yeah, so she had genetic testing on a comprehensive panel covering, 56 genes associated with cardiomyopathy of diverse phenotypes. Her findings were non-diagnostic, so 2 variants were identified. One variant in the DSP gene and one in FLNC. Interestingly, both are splicing variants, so you see the description C.170 plus 5 G to C. That's the G to C replacement. That's 5 base pairs away from an intrinsic splice site. So you can see the same thing, plus 5 G to A on the FLNC variant. And so splicing variants in these genes are a known mechanism of disease. So it raises suspicion that these are variants that could impact the splice site and therefore cause the disease. But there was insufficient evidence about these specific variants to make a hard claim that they were likely pathogenic or pathogenic. These are very rare variants. They're not seen in population databases, but they've never been described in patients with cardiomyopathy. So we weren't able to definitively adjudicate the variants, but we were highly suspicious. There was a degree of suspicion that possibly both could be contributing based on the phenotypic presentation, but especially the DSP variant, because I'm sure as we'll go into, DSP is strongly associated with episodes of hot phases and recurrent myocarditis-like episodes.
Thank you. So given the history that we have right now for our patient, what do you think?
So we have variants of unknown significance, desmoplakin, FLNC mutations. Should we do more imaging? Should we get some tissue? Should we go ahead and protect her with an ICD? Try medical management of these hot episodes? Or is there something else we should do? So here I'd like to ask Dr. Miller at this point, with what we have, a young woman, significant scar burden, desmoplakin mutation, but of unclear significance, 3% PVCs, she's not really having NSVT. We don't have a lot of literature yet in this population, particularly an LV predominant scar. How are you thinking about risk stratification? Is this someone you would ever consider for primary prevention ICD?
I mean, if you think she has a desmoplakin cardiomyopathy, the answer is yes. They can classically get a fair amount of scar before they ever get LV dysfunction. We do know that the incidence of sudden death or severe ventricular arrhythmias, I should say, is much higher in patients who have a high PVC burden. I think if I recall, in the largest registry to date, they called high PVC burden like more than 500 over 24 hours. So let's say 5% or whatever the number is. She had, let's say, 3%. But that's differentiating those who have like 80% incidence of severe ventricular arrhythmias versus 30%. So even if you have a normal Holter, they do have a high incidence of severe ventricular arrhythmias if you have significant scar burden. So I think all desmoplakin cardiomyopathy patients should get primary prevention ICDs if they have any evidence of significant LV scar burden, irrespective of the LV function and irrespective of the Holter. I know we do the Holter a lot. I'm not sure that necessarily helps you in one way or the other than saying how you stress it to the patient. Like if they have a 10% PVC burden with frequent polymorphic PVCs, and you tell the patient, you really need to have this done. If they have like no, benign Holter, you can say our recommendation is that you consider it. I'm not sure what it necessarily a cardiac does. We know a lot of these inflammatory cardiomyopathies, ARVD, all of them end up with some abnormal PET activity or FDG uptake. So I'm not sure necessarily how it changes the diagnosis, how it manages. If it's negative, it doesn't mean anything. If it's positive, it doesn't mean anything. And a biopsy is the same thing. A positive or negative biopsy, I'm not sure really changes anything, and that's the one with probably the most amount of risk. And trial of steroids I wouldn't do. We know from the ARVD population and even PVC population that when you give patients with inflammatory cardiomyopathies steroids, the PETs look better, the PVC burden goes down, but at some point, we don't know if it's protective, and at some point you have to take off the steroids and start the whole process again. So definitely wouldn't do steroids. But I agree with Amy that this episodic myopericarditis with that type of subepicardial LGE just smells like a desmoid plaque and cardiomyopathy.
Terrific. And Dr. Correa, I know management is going to change, or our hands are going to be forced by something else that happens in the history. But at this point, what are you thinking about what's the right next step? In particular, what are you thinking about pharmacotherapy, applying standard heart failure treatment to this more rare cardiomyopathy? Are you thinking about anti-inflammatories, SGLT2s?
Yeah, thanks for that question. So we had started conversations about an ICD. The furthering of the history we'll go through in a bit, but she was not particularly excited by the prospect of getting a defibrillator, both for cosmesis as well as just she didn't feel like she was that sick because she was minimally symptomatic. And I first started seeing her when I was a fellow here at Mount Sinai as a transplant fellow, and we were skeptical about whether to put her on guideline-directed medical therapy, to the extent that even though her ejection fraction was lower than normal, she was essentially asymptomatic. But I think within the heart failure community, there's a growing recognition that there is value to neurohormonal blockade, even in asymptomatic patients. There is value to the cardiometabolic effects of SGLT2 inhibitors. And so we sort of did it halfway. We started her, and then she had blood pressure room for an ARB. We felt like Entresto was too much, and so she had already been started by a previous cardiologist on a low-dose beta blocker for this ectopy and perception of palpitations, and so we decided to go with the ARB beta blocker route. And should she develop progression of her cardiomyopathy or more symptoms, then we'd go full court press with guideline-directed medical therapy. But my thought was that there was some value in putting her on heart failure medical therapy just due to its pleiotropic neurohormonal blocking effects.
Thank you. Moving forward, so the sister that we described before, she had a sudden cardiac death while traveling on a bus in Argentina. She was due to get her genetic appointment a week later, but apparently had a VFib arrest on the bus, and she did got some shocks, but she could not make through. And patient went to see her sister for her funeral, and where again she had an episode of chest pain and was hospitalized there again, and while being on colchicine and NSAIDs as well. As described by Dr. Korea, she was initially being skeptical about the ICD, but she was in constant touch with him after this episode, and it was decided that she gets an ICD after she returns to US. But prior to her EP visit, she again had an admission to the hospital with the chest pain. And just to brief, this was her EKG at the presentation, second presentation.
Anything major here, Dr. Miller? Still fractionated, anything else?
So her other labs were okay, but her troponins were markedly elevated during this admission with the peak of 39,000. So she did got the imaging at the time with the cardiac MRI, the short axis cine images.
Can you run us through this, Dr. Agarwal, particularly any comparison to the prior study? And I think we have a side-by-side comparison of the LGE coming up.
So again, the short So overall function, kind of pretty similar. Right? Maybe the left ventricle may be a little bit on the bigger side, but again, I don't see any major changes from last time to this time as far as the function is concerned.
Okay. So these are the long axis in images, 4, 3, and 2 chamber.
Again, nothing major over here. The lateral wall, the mid-lateral wall again looks a little bit probably sluggish or hypokinetic, especially that you see on the 3-chamber view.
Okay. So this is the LGE on this scan in a short axis view.
So the LG images over here are a little bit different from the previous ones. Again, you have a lot of the subepicardial LG pattern all over, but the difference that's there is, as opposed to the previous LG, which was more demarcated, the borders were a lot more sharp. If you look at the current one, the borders are a lot more soft because there is a lot more edema that is present towards the mid segments, that anterolateral wall that Shekhar is pointing to. So this kind of points more towards the fact that there is more acute inflammation as well that is happening. This LG that is there is not just because of the underlying fibrosis, but there is some edema component also that's there. But again, overall picture is that there is a large amount of this diffuse subepicardial LG, but slightly changed in characteristic than before.
Thank you. So we did the parametric values. At the first MRI, we had the values, as mentioned before, 942 of T1 and the T2 of 58. But in the second MRI that she had, her T1 values had increased. Her ECV was increased to 39%, and her T2 values were also increased to 62.1 as compared to the previous MRI.
I have a question from a naive standpoint as a non-imager. How appropriate or not is it to compare these parameters when the scans are done at different sites on different machines? I just don't know.
So that's a fair point in terms of all these numbers that are being created. They are created based on particular scanners, particular sequences, GAD dose and timing. So subtle differences, small differences are kind of tough to compare side by side. But again, if there are major changes or fluctuations that end up happening, then that is something that you can hold on to. Over here in this situation between 58 and 62 milliseconds, it doesn't really mean a whole lot. T1 between 942 and 1058, as Dr. Beanstalk mentioned before, it meant the patient was breathing, not breathing. So I would not put a lot of value just to this parametric value image mapping values in this patient. The other thing to keep in mind with parametric mapping values, especially with T1 and ECV, is they, in such patients, in a patient like this one, they complement what you see on your late gadolinium enhancement. They don't really change a lot of what you're seeing. So let's say you have a patient who does not have a lot of replacement fibrosis, and those patients, when your T1 or ECVs are elevated, then you pay a lot more attention to that. When you have such large amount of diffuse subepicardial LG, then the T1 and ECV in most situations does not add a whole lot by itself. And as Dr. Hadley mentioned, one of the things you have to be careful about is that what we know is fibrous tissue increases your T1 values and your fatty tissue decreases your T1 values. So it can get balanced out also. So you have to put it in context with the whole situation.
The aesthetics, because this comes up a lot, especially young females or defibrillators. Sorry. So it is a very common problem for young females not to want a defibrillator. I totally get that. There's a couple of things that we use to kind of get around that or like to convince them. First of all, it's very helpful if you put them in contact with a patient who also was in a similar circumstance, of a similar age and a similar gender, who had a defibrillator put in, who had similar concerns. And then the two of the patients talk with you not present is often a very helpful way for them to understand that it can be hidden really well, they can live a normal lifestyle. And I would say that 99% of patients that we put in contact with another patient and they talk by phone, they call the office saying they want to proceed. Because the way they see it is like in kind of an old person's type of device. I totally get that. And then sometimes you have to even go to the extreme, unfortunately, for a person like this, and tell them that you, for example, recommend they do not drive. And if you tell someone that you cannot drive, at least in your, what you believe for the time being without protection, they take it much more seriously because she's clearly very high risk for sudden death. And, God forbid she crashes her car into someone else one day. So, it's always a tough situation and people do as they see fit, but sometimes you really do have to kind of push them into the extreme in rare situations.
quick question about this patient in terms of ICD. When we are talking about ICD, obviously we're looking at the whole clinical picture, but if you're trying to justify the ICD, what criteria are we using to justify the ICD in this situation? Like by the book, if you were to say, what criteria does this patient check off, which ensures that this patient should be getting an ICD? The EF is not less than 40% or something, you're not having non-sustained ventricular tachycardia, that you're not meeting those criteria. So when we are having that conversation with the patient, other than presenting the big picture, is there anything else that we can hold on to or say that this is a checkbox that you meet, like when you're even trying to justify to the insurance company?
I think the insurance and CMS gives a lot of leeway nowadays to arrhythmogenic cardiomyopathies. It is rare that, very often, for example, they will deny it on first pass. You'll speak to a physician on a peer-to-peer, and I would say almost 100% of the time they approve it. So specifically for genetic cardiomyopathies, Brugadas, HOCMs, that sort of thing, we don't have to necessarily, there's no check boxes that we have to go through like we do for non-ischemic cardiomyopathy.
It's a great discussion. We're coming to the end of the hour here.
Can I just make one point?
Sure, 1 point, yeah.
Because Mike, you used the term mutation, because we don't know that this is DSP. I mean, it's highly suspicious for DSP, but to mark, I think you're going down the algorithm for decision-making. I don't think you can, initiate that through a DSP pathway. You have to focus on the phenotype, so calling it arrhythmogenic cardiomyopathy by phenotype, maybe that's how you justify it, but not by the genotype yet, even though I think in time we will learn that it is a DSP-related disease.
So can I ask maybe one question? So when you're summarizing this to the patient, you're saying, I just want to understand, because we get these VUS all the time, is you're saying this is an abnormal mutation. We don't know if this causes disease, and we don't know if this causes your type of disease. Is that fair?
So this is like a fine point, but I don't use the term mutation unless I have evidence that it's disease causing. And in this case, you don't. So I would use the term uncertain variant of uncertain significance. I mean, I think we were having a very frank conversation with her. By the way, there's a spectrum of variants of uncertain significance. There are ones that we don't have, that don't have features that would point you toward likelihood of being disease causing, and there are others that do. In this case, it was not, like, let's say, a missense variant. In DSP, a missense variant, it could be, it could not be, but a splicing variant, potential splice site variant, is much more suspicious for having a pathogenic impact. So we wanted her sister to get tested, and we felt quite strongly that if we could demonstrate that genotype-phenotype association in both of them, we could get the lab to reclassify, and unfortunately that never happened. But yeah, I mean, we tell her we can't be totally sure that it's DSP-related disease, but you're behaving very much like DSP-related disease. So yeah, I agree it was appropriate to go down the ICD decision-making pathway, but from a strict standpoint, you wouldn't be able to say this is definitely DSP disease based on the variant that she has.
Okay, Dr. Vora, can we get to the finish line? Please just tell us where we are now. I know there's a PET scan that we're not going to have time for.
Sure. She was managed in the CCU, and heart failure was consulting. She was pulsed with steroids during the CCU stay, followed by steroid taper. She had a PET CT after the steroid pulse. She had FTG PET, but in the interest of time, I think just go over it quickly. It was normal. There was no evidence of any inflammation on the FTG PET.
Why was that? Why the PET was that?
To rule out any inflammation as well, like on
That's steroids. You get the PET after steroids.
I want to give context to that. So first of all, the steroids were given in the context of bias for action. I frankly didn't know what we were doing at the time. And the timeline was actually much more compressed. She got chest pain on the plane coming back from her sister's funeral in Argentina and came straight to the Mount Sinai West emergency room with elevated troponin. So out of a bias for action, she was pulsed with steroids. But she got the PET scan a few hours after her first dose of prednisone. So I don't think there was very many steroids in her system at the time. The PET scan was just, again, bias for action, looking for inflammation, looking for some evidence of ongoing inflammation to help prognosticate how she was doing at the time.
So EP was consulted as well, and she got a sub-Q ICD for the primary prevention as well during her ICU stay. So what we have now is the patient with the recurrent chest pains, with troponin elevations, with the positive genetics in the form of variant of unknown significance, MRI findings of subepicardial LGE, and significant family history. So we think it's probably a cause of a presumed inflammatory cardiomyopathy, likely desmoplakin cardiomyopathy.
That's great. And Dr. Correa, tell us where we are today. How are you managing her going forward?
She's now developing mild heart failure symptoms. There's also some supratentorial component. She also has very, very significant anxiety. I've put her on an SGLT2 inhibitor, but she's living her best life. She's graduated from Columbia Business School. She's yeah. Um, she's going to be seeing Amy again soon because she's thinking about family planning now.
Yeah.
And she's doing okay. But the thing about if this is desmoplakin cardiomyopathy, and my approach, I was thinking about this in a much more simplistic way. If it looks like a duck and quacks like a duck and it smells like a duck. So I think she has some form of desmoplakin cardiomyopathy, and we have many patients with desmoplakin cardiomyopathy. My partner R.A. Fox, who reviewed this case with me before we were thinking of this being a desmoplakin cardiomyopathy, said, I have similar patients like this who have come with these hot phase episodes with myocarditis. Both of those patients are transplanted now. So I don't know which way the wind will blow. Right now she's doing okay. But if she's going to behave like the other patients, she's eventually going to have progressive dilation of her ventricle, possibly more myocarditis episodes. And so I've invoked her heart disease getting more severe in the future.
Is there activity restriction for these patients?
So, she's an extremely athletic, active person, and that's the majority of our visits have been spent debating and discussing what she can and cannot do. When she didn't have an ICD, I sort of used language similar to what Mark was suggesting. I told her she can't swim. I told her she should not exercise. I've sort of walked back that now more recently. But I don't know, maybe Amy can tell us what advice would you give about exercise?
You also mentioned counseling on pregnancy and exercise?
Time, but this reminds me of being grilled by Mark Harrison as a fellow. Do you remember him? For a patient with dyspnea and heart failure symptoms who also had COPD. You have to make a choice, right? You have to decide, like, what are you calling this diagnosis? We can't definitively say it's DSP associated. It's not really positive genetics. But if you think this is an arrhythmogenic cardiomyopathy with myocarditis-like flares, I think that's okay to say it. And in that case, you do need to invoke some exercise restrictions because we know that exercise is a trigger of these flares and exacerbation of both the arrhythmogenic phenotype and the cardiomyopathy. So I do think it's appropriate to restrict exercise. You don't have to be dogmatic about it. Patients can engage in low to moderate exercise. I don't know, Mark, if you disagree at all, but you don't want them doing extreme exercise. I think there's some data in at least LMNA disease that looks at a threshold of about 2.1 hours of low moderate exercise per week. Anything above that worsens the outcomes, and anything below that seems to not be associated with worsened outcomes. And you asked me to comment about pregnancy. So in the absence of having, first of all, there's two issues. There's the health of the mother and the ability to sustain a pregnancy, and I think, Ashish, it's really important for her to see you and make sure that you feel that she's cleared from a cardiac perspective to carry a pregnancy. There's an increased risk of peripartum cardiomyopathy in people who carry DSP variants and FLNC variants that are known to be disease-causing. Again, we don't know that here, but highly likely. So it's possible that pregnancy could exacerbate her cardiomyopathy. And then there's the family planning aspect. Unless you have a definitive known disease-causing variant, you can't use these genetic results for any pre-implantation genetic testing. The lab won't create a probe for a variant of uncertain significance.
Thanks very much. I want to give the audience a chance for questions both here and Morningside West. Other centers joining, please feel free to jump in. Dr. Stern has a question.
Two questions. One, when she comes, just a plea, when she comes back from Argentina after the death of her sister, just think about Takotsubo because she's not protected. So that's one thing to think about, irrespective of ECG. The second is, this sort of calls out phenotypically for Naxos or something similar to that. So, I mean, My knowledge is trivial, but that's the sort of stuff with the funny hands and the curly hair in terms of forgetting about how her body gets to do what it's doing. Seems to be behaving that way in terms of what her body is producing. I don't know that. It's one of these, as you're saying, Amy, it could be two things together. And that's, we're stuck. And I presume there's no ultra-structural way for us to actually get tissue and say, oh, gee, look, there's something defect.
It's tempting, but Naxos would involve biallelic mutations, and she only had one DSP variant. There's no known association with either the hair phenotype or the skin phenotype in an autosomal dominant DSP-related disease. I think there was a little bit of a red herring. It's always tempting. I think it looked like she had some eczema on